Good afternoon, everybody. Not afternoon yet, morning. Good morning, everybody. So we're about to get started for the Pecha Kuchas. I just want to double check if Hassan Hutchison, okay, yep, you're great. All right, so welcome everyone to our first Pecha Kucha. We have another concurrent Pecha Kucha going on in Stevens. So good morning and welcome to our Pecha Kuchas. My name is Rebecca and I'll be your moderator for this session. To start things off, it's my pleasure to introduce you to our judges, Jenifer Brown, Hassan Hutchinson, and Jacob Shelley. So on behalf of the Canadian Obesity Network, I would like to thank you for providing us with your time and fair judgment today. Feature Pecha Kucha presentations for the 2017 Canadian Obesity Summit represent the top scoring abstracts, so already a huge feat. And prizes will be awarded to the best presentations at the summit closing ceremony on Friday, April 28th at 4:30. Along with their presentation today, you can check out their poster in the Riverview Lounge, which will be up until Friday, April 28th. So for our speakers, as you know, you have 20 slides, and each slide will be shown for 20 seconds, so the slides will advance automatically. I'll announce your name and your title for your presentation, then your time will begin. Unless there's time at the end, there won't be any question period, but we do encourage the audience to approach the presenters at the end of the session and also at their poster presentation to ask more questions. So I'll begin by calling the first presenter to the podium, Sarah Nutter, who will be presenting Food, Eating, and Weight, Language, Discourses, and Debates in the Obesity Field.
It's okay. We're just going to wait for the slides to start. I know, right? Perfect. There we go. Okay, so hello everybody. My name is Sarah and this is Molly, and we're from the University of Calgary under the supervision of Dr. Shelley Russell-Mayhew. Today we'll briefly be discussing two studies that have emerged from our lab. One, a project I worked on with Drs. Russell-Mayhew, Alberga, McInnes, and Ellard, and the second is Molly's master's project. These two studies complement one another as they both focused on examining tensions in research related to obesity, eating, and eating disorders. These two research studies also attempt to identify and bridge significant gaps in research to further future research efforts and improve patient care.
Historically, obesity and eating disorders have been considered separate concerns, with professionals and researchers from these areas often working in opposition. To better understand the tension between the two fields, I examined how food, eating, and weight were differently talked about and represented at eating disorder conferences and obesity conferences. Specifically, I studied the 2011, 2013, and 2015 Canadian Obesity Summits and the 2012, 2014, and 2016 Eating Disorders Association of Canada conferences. I used a social constructionist situational analysis approach to examine food menus and abstracts of presentations from these conferences. Today, I'll discuss two of my findings from my study. First, the way dieting was taken up within the abstracts from the obesity and eating disorder conferences. And second, the way food was presented for delegates at the 2015 Canadian Obesity Summit and the 2014 Eating Disorders Association of Canada conference. My results suggest the presence of contradictory messages. For example, dieting and exercising to lose weight were considered effective and ineffective within the obesity data, but dieting and exercising to lose weight were considered both ineffective and dangerous in promoting eating disorders within the eating disorder data. Food was also presented in different ways. For example, at the Canadian Obesity Summit, breakfast and snacks were served as buffets with plenty of options, but lunch was served in individual brown bags, which highlighted and encouraged portion control and low-fat foods. There was also a sign that encouraged healthy eating and low-calorie options. On the other hand, all meals and snacks at the Eating Disorders Association of Canada conference were presented as buffets with plenty of options. There was no mention of healthy eating, portion control, low-fat foods, or low-calorie foods at these conferences, indicating a different values across conferences. By examining the different ways in which eating disorder and obesity professionals talk about food, eating, and weight, I highlight the need to adopt a more integrative approach to prevent a wide range of eating and weight-related concerns. A more harmonious prevention approach could have positive health outcomes and provide the public with more coherent messages.
So Molly's study examined contested ideas between the eating disorder and obesity fields. The second study looked at contested ideas about language related to weight. Weight bias researchers comprise individuals from multiple disciplinary backgrounds who are strongly divided between two dominant perspectives on weight terms. One group of researchers supports the use of the word obesity and person-first language, and the other group strongly opposes the word obesity, instead preferring to use the word fat and identity-first language. Despite researchers in both fields aiming to reduce weight bias, these tensions have resulted in research silos. So Pohl and colleagues investigated the reactions of members of the general public to different weight terms used by healthcare professionals. They looked at 10 different weight terms with regard to the degree that they were perceived to be desirable, stigmatizing, blaming, and motivating. As you can see here, the terms fat and obese were both rated as being less desirable, more stigmatizing, and more blaming, with obese also being rated as less motivating. Despite these and similar research findings, weight bias researchers continue to be divided and to have strong positions on language terms. In order to find a way to bridge these research silos and to make weight bias in weight bias research and to make suggestions for moving forward, we wanted to further investigate the opinions of members of the general public regarding the words fat and obese, and to correlate use of these words to negative attitudes towards people with obesity. Inspired by the research conducted by Pohl and colleagues, we asked members of the general public the two questions that you see here on the slide. 397 participants responded to these questions, which were featured as part of a larger study. We used an open-ended question so that we could also examine other commonly used and socially acceptable weight terms that participants regarded. So here are the words that were the most common responses to these two questions. It's noteworthy to see that the word fat was overwhelmingly identified as being a common descriptor, but not often regarded as socially acceptable. It's also noteworthy to see that the word obese was reported by about the same number of respondents for both questions. The occurrence of these words in general, and the word fat in particular, did not significantly differ for individuals in different BMI categories. However, use of the word fat was associated with a small but significant difference in attitudes towards people living with obesity, with people using the word fat having more negative attitudes. So our findings further demonstrate that the tensions around weight terms are complex. Given our results, we echo the conclusion of previous researchers that there needs to be increased awareness and training with regard to weight bias in practice. Researchers have stated that it is important to be mindful that no weight term will be completely free of stigma. Therefore, it may be important to ask patients about their preferred term in order to increase their sense of respect and improve the working relationship with our patients. Finally, it's important to respect that labeling preferences will change with time and will vary between the individuals that we work with. And so, in summary, we as researchers are interested in examining the debates and tensions within and across these fields for the purposes of trying to build bridges and to work towards better care for all patients. We aim to inform future preventive and collaborative practices. Thank you.
Thank you, Sarah. So our second speaker is Diana Tarraf, who will be presenting food insecurity, diet quality, and obesity in African and Caribbean households in Ottawa.
Thank you for the invitation. So as mentioned, my presentation will be on food insecurity, diet quality, in immigrant children in Ottawa. So to begin, food security is defined as sufficient access to food for a healthy and active life, and that includes both physical and economic access to food that meets people's dietary needs and their food preferences. In Canada, there's about 1.1 million households who suffer from food insecurity, and the rates are higher among recent immigrants compared to the general Canadian population. People who have a low income and who are dependent on social assistance programs are more vulnerable to food insecurity. So food insecurity is increasingly being recognized as a public health problem because it's linked with higher rates of self-reported poor health and chronic health conditions, including depression, diabetes, and heart disease. And among children, it's linked with a lower diet quality, nutrient deficiencies such as anemia, a higher body mass index, so a higher prevalence of overweight and obesity, and a poor psychosocial status. So we know that there's a high proportion of Black immigrants in Ottawa. They comprise about 24.2% of the total visible minority population, but there's not much data on their food security situation, especially among those of African and Caribbean descent, and especially among children. And knowing that situation would help improve our understanding of what makes them more vulnerable. So my objectives were to assess the relationship between food security and immigration status, to identify socio-demographic determinants of food insecurity of households, and to assess the relationship between food insecurity, diet quality, and weight status of children and their mothers. Our study sample was comprised of mothers and their children between the ages of 6 and 12 years living in Ottawa. We had about 120 households of sub-Saharan African descent, 62 from the Caribbean, and 67 from Canada, for a total of 249 child-mother pairs. To collect the data, we conducted individual face-to-face interviews with the mother and their child. We measured their height and weight, and the questionnaire included questions on demographics, knowledge of official languages, and we used the household food security survey module used by Health Canada. We also had one 24-hour dietary recall carried out with a standardized protocol. To measure diet quality, we used the Canadian Healthy Eating Index, which is an indicator of nutrient adequacy among many others. It was revised in 2009 with Health Canada's new Eating Well with Canada's Food Guide. It's a validated tool, and we used it because it would facilitate comparisons with other Canadian studies. So to analyze the 24-hour recalls, we used Esra Food Processor with the Canadian nutrient file, and then we went ahead and inputted the Healthy Eating Index score. So moving on to our results, 39% of households were food insecure in our sample, and among those, 20.9% had moderate food insecurity. This is much higher than the 12.3% reported for the general Canadian population. So this figure shows the prevalence of food insecurity by immigration category. And when we look at the food secure group, we see that over 40% are economic migrants. And when looking at the food insecure group, we see that 50% of them are refugees. We had about an equal amount of family class migrants in both groups. So this is a logistic regression analysis exploring the sample characteristics in relation to household food security over the past year. Some important predictors were household receiving social assistance, the mother having a high school diploma or less, lone mother household, and visible minority status. When it comes to the diet quality of the sample, the mean healthy eating index score was 74 over 100, which is categorized as needs improvement. The mean vegetables and fruit subscore was only 13.4 over 20, and the mean sodium intake was over 2400, which is above the upper limit recommended by Health Canada. When looking at this table shows the impact of household food insecurity on children's dietary intake. So household food insecurity predicted a higher intake of sugar-sweetened beverages and a lower intake of saturated fat. When looking at the prevalence of obesity, we didn't see an association between household food security and obesity among children, but there was a significant association with mothers. So 55.2% of food insecure mothers were obese, compared to just 35.7% of those who were food secure. Moving on to the discussion, household food insecurity was linked with material deprivation, visible minority status, and the children's diet quality. Overall, it needed improvement. There was a high consumption of sodium, a high consumption of other foods, and a low consumption of vegetables and fruit. Food insecurity was linked with certain indicators of diet quality, but not with the overall healthy eating index score. It was linked with a lower consumption of saturated fats and a higher consumption of sugar-sweetened beverages. In this sample, food insecurity was linked with overweight and obesity among mothers, but not with children. And other studies have found similar results. Our study limitations include the 24-hour recall, so we only did one to reduce the burden on participants, so their intake may not be representative. There was also a selection bias because the study was conducted on volunteers, and it was a very hard to reach population, so the sample size may not have been as large as we wanted to. Food insecurity should be a target for policy intervention, so there should be affordable childcare and well-paid jobs and improved social assistance programs to meet people's dietary needs. We also need to have better immigrant integration strategies, and expanding school and community-based responses would help as well. Thank you.
Okay, thank you, Diana. And our next speaker, our final speaker, is Jenifer Bennett, who will be presenting Addressing Weight Bias in a Provincial Health Services Organization.
I worked as a nurse in the adult intensive care unit for 8 years. One shift, I was assigned to a patient who had obesity and had been in a car crash. She was admitted, multiple trauma, had been unstable for a couple of days. One concern I had for rounds with the physician team was that we hadn't initiated any nutrition plans. The physician listened to my concern, looked into the patient's room and said, "I think she can live off the fat of the land." A friend told me a story of his experience in hospital following his gastric bypass. The hospital where he had the procedure was the only hospital in Edmonton that does this surgery. My friend was admitted to a room that he shared with 3 other people, and all the patients in the room shared one bathroom. One morning, the charge nurse approached him at his bedside and stated he could no longer use the shared toilet in the room. He was too heavy for it. When asked how he was supposed to go to the washroom, he was told a bariatric commode chair would be brought to his bedside. Oh, there would be fabric dividers for his privacy. Well, that was very little privacy. This transaction took place in front of the other patients in the room and left my friend humiliated and angry. This is the weight bias that occurs again and again through our healthcare system. We need to recognize that it exists, and it is affecting the way our patients access and accept care. Experiencing weight bias from healthcare providers can deter patients from seeking care. Given the complexity of disease that many of our patients suffer from, delays in seeking treatment certainly contributes to poorly managed chronic illness and a need for increased resources down the road. This bias may also prevent patients from accessing routine screening. If you go to the doctor's office for your yearly physical and pap smear, a healthy 26-year-old woman, and get lectured for 30 minutes on why you need to lose weight now, are you likely to want to repeat that experience? These types of concerns and experiences further contribute to the isolation, blame, and shame so many people with obesity struggle with daily. After years of working with patients who have told me many stories of bias and having both witnessed and yes, been guilty of weight bias myself, I recognized along with my colleagues Dr. Mary Forhan and Kathy Danzinger a need to effect change. We began talking about this and quickly recognized that there's a lack of education about the disease of obesity. Kathy and I recently had the opportunity to edit a chapter on nursing care for patients with obesity in a medical surgical nursing textbook. One of our biggest jobs was ensuring all language was changed to person first by removing the term bariatric patient. Not only does lack of education contribute to attitudinal bias, it prevents us from looking at the treatment of obesity and patients with obesity as people who have a unique set of needs and may require a different type of care. We don't think about the way obesity may affect anatomy, physiology, response to certain treatments. We simply adapt standard guidelines to a bigger person. When you look around our medical facilities, the absence of specific protocols to accommodate people with obesity can be seen in the amount and type of equipment available, and even the design of the buildings patients receive treatment in. While we've purchased more appropriate equipment to support our patients with obesity, just accessing some areas of the hospitals can be a challenge. Lack of handicap parking is a common complaint. Our own bariatric specialty clinic is in an old building on the 4th floor and has very narrow elevators, making it difficult for patients who require scooters or wheelchairs. Kathy, Mary, and I, decided to aim high and make our goal to have mandatory weight bias education implemented across all zones and job types in Alberta Health Services. Not a small achievement. We knew we first had to prove that there's a need for this type of education, and so we needed to assess where our current attitudes were. A study is born. To determine the potential for weight bias amongst healthcare professionals at AHS, we asked all employees and physicians in the Edmonton zone to complete the attitudes toward and beliefs about obese persons questionnaires. 423 people completed the questionnaires, and results showed responses indicating a negative attitude towards persons with obesity. We shared these results in a newsletter that is sent to all staff in the Edmonton zone, along with the messaging that this was an expected result, it's in line with research in the area of weight bias, and that the information gathered did support our belief that there is a need to provide professional education. We followed this up with a survey about the methods by which to reduce weight bias at AHS. Over 90% of the 210 people who responded agreed that weight bias education and training was needed for all employees who come into contact with patients. When asked what topics they would like to receive education about, top requests included information about the causes of obesity, the physical and emotional consequences of obesity, and strategies to make healthcare environments more accessible and safe. One thing I found interesting from the results was that 90% of respondents wanted more information and skills training on how to talk with patients about obesity. We know that many healthcare providers are uncomfortable with opening this conversation, so it was interesting to me that the respondents were able to recognize this lack of skill and identify it as an area they wish to improve. Providing this type of education could certainly increase the number and types of conversations patients encounter while accessing different treatments. We felt it was important to not only just identify that weight bias exists, but we wanted to hear from the respondents what kind of information they wanted and how we could most efficiently deliver that education. We recognize our target audience would be made up of adult learners who have many priorities and limited time in many cases. Over 50% of respondents indicated they would most likely participate in training that was offered online or in a combination of online learning and face-to-face strategies. This aligns with current education delivery strategies used throughout AHS and would be familiar to employees. Accessibility and familiarity should improve staff interest. Our next step is to publish our findings to increase awareness and highlight its importance as a priority. This may be the most challenging aspect of our project, as there are many competing priorities when looking at staff education. We would argue, however, that weight bias occurs at all levels of service and affects not only care provided to patients, but the work environment of our employees. We hope to meet with the appropriate people at AHS to partner in developing and delivering education to all staff members. It is only through education and with strength in numbers that we can begin to change this culture. Thank you.
Okay, thank you to all our presenters. Can we give them maybe another round of applause for starting us off? Thank you. So just as a reminder, the best overall presentations will be announced at the closing ceremonies on Friday, April 28th at 4:30. Now feel free to help yourself to lunch in the Van Horn for the buffet lunch or Riverview for a box lunch. And thank you again.